So stage is yours, Dr. Rujul. You can start with the proceedings.
Good evening, all the esteemed members. I thank Dr. Pawan Goyal sir to have given me the opportunity to present before such an august members. So today we will be discussing about a relatively new topic, that is diabetes remission. So previously diabetes management was solely focused on the glucocentric part. We were always thought about that how we can control the diabetes effectively. But in the last 10 or few years, diabetes remission has been the latest advancement in the diabetes management. So we will see that whether diabetes remission is really a myth or it is achievable. So diabetes, as we all have been taught from our MBBS days, that it is a permanent, inevitably progressive disease. And previously, the management of diabetes was based and was solely concentrated on glycemic control. And we were taught that ultimately there will be beta cell failure and we cannot avoid the downward trajectory towards beta cell failure. We can see that these are the various stages of diabetes. So as the beta cell secretory reserve it decreases, then patient tends to progress from pre-diabetes to type 2 diabetes. Initially, there is insulin resistance, which is managed by compensatory increase in the insulin secretory drive. But ultimately, the insulin secretory drive is been overwhelmed and it leads to type 2 diabetes. But in around 2010, few studies and meta-analysis showed that durable normoglycemic state can be achieved through various methods like bariatric surgery, intensive therapeutic interventions, and significant lifestyle modifications. And it was also seen that we can also restore the functional beta cell mass to a normal level. So first in 2009, an expert consensus introduced the concept of remission for the first time. So there were few terms, whether we should label it as diabetes reversal, diabetes remission, or diabetes cure. Initially, these all terms were used interchangeably, but there are subtle differences in these terms, and ultimately it was decided that diabetes remission is the best term because remission implies that disease progression has been partially reversed or arrested, but it can be reactivated, resulting in relapse. Means that we have been able to halt the progression of diabetes, but we should be cautious. We should follow up the patient because it is ultimately not permanent. Whereas cure word means that we have completely eradicated the diabetes and pancreatic function has been restored to normal, which is currently not possible. Then there is a term diabetes reversal. So the term reversal can misleadingly imply that permanent cure of the disease has happened or the disease has been entirely eradicated. And the term diabetes reversal can give a false notion to the patient that there is no need for further clinical follow-up or management. So which is a key reason medical professionals prefer the term remission. So diabetes reversal is not a standardized term in medical practice. So what is the current definition of diabetes remission? So diabetes remission was defined in the consensus report of 2021 and it was endorsed by various societies like Endocrine Society of USA, ESD, European Association of Study of Diabetes, American Diabetes Association, Diabetes UK. So this term is defined by return of HbA1c to less than 6.5% that occurs spontaneously or following an intervention, and it should persist for at least 3 months in the absence of the usual glucose lowering pharmacotherapy. So in pure term, simple language, if we understand that if we are able to achieve HbA1c of less than 6.5%, and it has been maintained for at least 3 months without giving any uh, glucose lowering drug for the patient, then according to this definition, patient has achieved diabetes remission. But continuous follow-up is definitely required. At least annually, HbA1c and other glycemic parameters should be checked, because we have seen in the previous slides, ultimately this thing, it is usually not permanent. So this is the previous classification, previous definition, which was given in 2009. So earlier there were three terms: partial remission, complete remission, and prolonged remission. So partial remission was hyperglycemia below the diagnostic threshold for diabetes, and it has to be maintained for at least 1 year, and no active pharmacologic therapy or ongoing procedures. And complete remission was if HbA1c was within the normal glycemic measures, and if complete remission was achieved for at least 5 years duration, then it was labeled as prolonged remission. So in 2021, these all definitions were revised, and they gave just a single term, diabetes remission, because the three different terminologies was giving confusion, and the duration of diabetes remission was ultimately removed, that whether it is prolonged remission, complete. So just if HbA1c persists less than, it is below 6.5%, and it persists for at least 3 months, then we can label as diabetes remission. Or if HbA1c cannot be measured, then fasting plasma glucose should be less than 126, or if continuous glucose monitoring parameters are available, then based on TIR, estimated HbA1c should be less than 6.5. So why this definition was changed? Because ultimately it was changed to a single diagnostic standard, because the previous classification of 2009 was considered complex, and there was lack of evidence for standards of blood glucose level and maintenance period. So there are some pitfalls in diabetes remission definition. The HbA1c cutoff, which has been defined below 6.5%, because it does not rule out the possibility of developing typical diabetic complications, because various long-term studies, they have shown that sometimes cardiovascular risk begins to increase even before this cutoff. And if we say to a patient that you have achieved diabetes remission, so there is a risk that it may generate a false sense of security in the patient, and this may in turn lead to an early abandonment of the necessary follow-up, and consequently inadequate control of other cardiovascular risk factors. So this false sense of security was, it was more in the term of diabetes reversal, because patient might think that he has completely eradicated the diabetes. So then diabetes remission was thought to be a more reasonable term. So now we will see that how diabetes remission can be achieved, what are the basic pathophysiological factors, and how beta cell mass and weight loss, they play a crucial role in achieving diabetes remission. So this is a basic diagram which shows that how the beta cell mass is regulated. So new beta cells are formed by replication or neogenesis, and ultimately there is a balance between apoptosis and new formation. And these three terms are important, because beta cell, they can redifferentiate into other cells, they can de-differentiate into other cells, and then they can permanently de-differentiate, which is called as transdifferentiation. But de-differentiated cells can sometimes redifferentiate into beta cells again. So this redifferentiation is important for achieving diabetes remission. So beta cell dysfunction plays a vital role in the development of diabetes, and there is a dynamic equilibrium between beta cell proliferation, which is achieved through replication and neogenesis, and beta cell loss through apoptosis. So identity of beta cells, it is altered in two ways: dedifferentiation and transdifferentiation. So transdifferentiated beta cells cannot be redifferentiated, but dedifferentiated beta cells can be targeted, and then again converting them into a functional beta cell could be a potential target to achieve diabetes remission. Another core hypothesis for diabetes remission, we can say that the foundation principle of diabetes remission is the twin cycle hypothesis, which was proposed by Professor Roy Taylor. And he proposed that diabetes is basically a result of excessive liver fat. So due to excessive fat accumulation in the liver, there is increased hepatic VLDL, and this hepatic VLDL triglyceride is exported to the ectopic tissues, and one such tissue in which it is exported is the pancreas. So uptake and storage of fatty acids in the pancreas will initiate the pancreatic cycle, and prolonged lipotoxicity in the pancreas can lead to pancreatic beta cell dysfunction. So ultimately, weight loss will cause a decrease in the intrahepatic fat, leading to reversal of hepatic insulin resistance, and gradually, with the continuation of caloric restriction, intrapancreatic fat content will also decrease. So we can understand through this diagram that there is increased liver fat due to excess calorie consumption, and this leads to increased VLDL triglyceride, which is exported to the pancreatic beta cells, and it leads to decreased insulin responsiveness to glucose, and increased liver fat is also due to resistance to insulin suppression of hepatic glucose production, which also leads to increased basal insulin secretion, which further potentiates this cycle. So we have seen that in the definition, there was term that achieving diabetes remission either spontaneously or through some intervention. So the question which comes to our mind, that whether spontaneous diabetes remission is possible, means that we have not done any specific intervention and still diabetes goes into remission. So there are some long-term studies which have seen that whether spontaneous diabetes remission is possible. So in a US study of 122,780 adult type 2 diabetic patients, it reported that 7-year cumulative incidence of remission was just 1.6%. And it was higher in patients who had early diabetes, that is less than 2 years from diagnosis. Similarly, in a study from England, which enrolled around 229,000 diabetic patients, it showed that only 1.7% achieved criteria for diabetes remission. So we can see that the spontaneous rate of diabetes remission is very less. It is just around 1.5 to 2%. So the next relevant question which comes to our mind, that what are the predictors of diabetes remission? In which subset of patients we should even think about diabetes remission? So diabetes remission is basically dependent on two main determinants, that how much weight loss patient has achieved and what is his baseline pancreatic beta cell function. So energy restriction and substantial weight loss, they are primary factors in inducing and maintaining diabetes remission, and beta cell reserve capable of functional reactivation is an absolute necessity. So basically, some patients, they are able to achieve weight loss and they are even able to sustain it but still their diabetes remission does not happen, because if their baseline beta cell reserve is very less, then just sustained weight loss may not be able to achieve diabetes remission. So what are the clinical indicators of better beta cell function? How we can predict, and what are the clinical predictors in day-to-day practice by which we can assume that these subset of patients may have an increased chance of diabetes remission. If the patient is having lower HbA1c, some studies have shown that HbA1c less than 7.5 is a good predictor. If patient is on fewer diabetic medications, and specifically patient should not be on insulin or sulfonylureas, because if patient is already needing insulin or sulfonylureas, that is secretagogues, that is an indirect indication that his pancreatic beta cell function is less. Shorter known duration of diabetes and younger age. So we can see that some positive predictors of type 2 diabetes remission are if patient has high adherence to physical activity program, GLP-1 receptor agonist, recently more widely available, 15% total weight loss at 12 months, or even 10% total weight loss at 12 months. Negative predictors are if patient is already on insulin, diabetes duration more than 7 years. Some studies have shown that diabetes duration more than 5 years is also a negative predictor, and if baseline HbA1c is more than 7.6. So recently, artificial intelligence has also come up a big way in medical practice. So there are some emerging approaches in predicting diabetes remission. There is a role of biomarkers like C-peptide, adiponectin, genetic polymorphisms, including variants in transcription factor 7L2, and fat and obesity-related genes. So AI-driven models can identify complex interactions among clinical, genetic, and metabolic variables. So now we come to the various techniques of achieving diabetes remission. So the uh, most important technique of achieving diabetes remission is metabolic surgery, which was earlier known as bariatric surgery, because this was the core thing by which the concept of diabetes remission arose. And through these techniques only, we started thinking that we can even achieve diabetes remission. So since its introduction in 1990, different techniques have been developed, like gastric bending, vertical bended gastroplasty, sleeve gastrectomy, Roux-en-Y gastric bypass, biliopancreatic diversion, with or without duodenal switching. So broadly, they are classified into malabsorptive or restrictive techniques, and sleeve gastrectomy and gastric bypass are currently the most common techniques which are used. So indication of metabolic bariatric surgery has also changed over last 10 years. So earlier, BMI of more than 40 or more than 35 if in the presence of comorbidities was the indication. So even BMI of 30 to 34.9 was also indicated. And in the Asian population, BMI of above 27.5 has been given level of evidence safe for offering metabolic bariatric surgery. So we can see that how the practice guidelines of ADA regarding the surgery indication has changed over years. So first, the bariatric surgery concept came in 2009. First time it was incorporated in the 2009 ADA guidelines, because we all know that ADA is the primary governing body for diabetes management, and it releases its annual guidelines for diabetes management. So for first time in 2009, the bariatric surgery appeared in its guidelines. And at that time, it was the BMI of more than 35, it labeled as level of evidence B. Then in 2016, a new section was added. And in 2017, the terminology was changed from metabolic surgery. It was changed from bariatric surgery to metabolic surgery. So we can see that diabetes with BMI more than 40 or 35 to 39.9 with hyperglycemia. And in Asians, the BMI cutoff was less by 2.5. And between 30 to 34.9 BMI, the level of evidence was B. In 2019, the evidence level was changed. So between 30 to 34.9, the level of evidence was changed from B to A. And in 2020, the BMI category was changed. So guidelines stated that BMI more than 30 should be offered metabolic surgery. And in Asians, the BMI was more than 27.5. So what is the rate of diabetes remission after bariatric surgery? So these are the various randomized control trials which have assessed the diabetes remission rates after metabolic surgery. So broadly, if we see, the remission rate is between 60 to 80% at 5 years after uh, metabolic surgery. So if we see the outcomes comparing various modes of metabolic surgery with intensive lifestyle management, we can see that 95, 60, 58%, and earlier studies, the rate was around 50%. So overall, it is between 60 to 80%. And if we see the systematic reviews regarding the diabetes remission with metabolic surgery, so we can see that the remission percentage in RCT, it was around 92%. Similarly, some studies even tried it in type 1 diabetes who are obese. So they saw that the insulin requirement decreased. In type 2 diabetes, 76% became insulin free. There was 60% patients who became medication free. So the question which comes to our mind, that what is the basic factor which is driving this diabetes remission? So an interesting point about the metabolic surgery is that remission of diabetes usually occurs very early, as early as 2 to 3 days to 2 to 3 weeks, even when the weight loss has not yet occurred. So this means the remission due to metabolic surgery is not solely dependent on weight loss, because the remission starts to happen even before the weight loss has occurred. So there are some other factors which are driving this diabetes remission. So these are the various postulated mechanisms of diabetes remission after metabolic surgery. So Roux-en-Y gastric bypass and sleeve gastrectomy, these are the two most common techniques preferred nowadays. So it leads to the immediate impact. It leads to caloric restriction, rapid emptying of nutrients into the small intestine. Sleeve gastrectomy, there is removal of the stomach fundus. Roux-en-Y gastric bypass, it excludes the duodenum and proximal jejunum from the nutrients. So these all leads to altered bile acid, FGF19 signaling, altered microbiome, gut hormones, particularly the incretins, altered neural signaling, intestinal adaptation is changed, reduced hepatic and pancreatic triglycerides. Weight loss is also, it is a major factor, but weight loss usually does not occur very early. Even early when diabetes remission starts to happen. The other second technique for achieving diabetes remission, first we have seen that it was metabolic surgery. The second technique for achieving diabetes remission is intensive lifestyle management, that is therapeutic lifestyle change for achieving diabetes remission. So diabetes remission is possible by restriction of food energy to achieve a body weight loss of around 15 kg. We have seen earlier through the twin cycle hypothesis that weight loss decreases both the liver and pancreatic fat, thus improving the insulin sensitivity and improving the beta cell function. So these are some of the famous trials which studied the role of intensive lifestyle management in achieving diabetes remission. So direct trial, it was done basically through a very low calorie diet using meal replacement. So remission rate was 46% at 1 year and 36% at 2 years, as compared to just around 4% in the control groups. Diademi trial, it again used very low calorie diets and achieved a significant weight loss of around 12 kg. So the remission rate was 61% at 1 year. Direct Australia trial, over half of the newly diagnosed diabetic patients achieved remission after 1 year of intensive lifestyle management using low energy total diet replacement. And even lean individuals whose BMI was less than 25, they can also benefit from intensive physical activity and dietary program to achieve diabetes remission. So look ahead, which was Action for Health for Diabetes study. It is the largest multicentric RCT of an intensive lifestyle intervention among adults with diabetes. So around 5,145 diabetic overweight adults with BMI more than 25 with mean duration of diabetes of 5 years. They were randomized to either an intensive lifestyle based weight loss intervention or a diabetes support and education intervention. So the intervention group underwent a strict counseling program with total caloric intake of 1200 to 1800 calories per day through reductions in total and saturated fat intake and by increasing the physical activity levels to at least 175 minutes per week. The intervention group was significantly more likely to have a sustained remission both at year 2, that was 9.2%, and year 4, that was around 3.5%. So previous studies, the remission rate was around 40 to 50%, but this study showed the remission rate of around 10% and around 5% at 1 and 4 years, because those studies mainly enrolled newly diagnosed type 2 diabetes, and this study enrolled patients with duration of around 5 years. So these are some of the standard terminologies used for defining the carbohydrate restriction. So very low carbohydrate or ketogenic diet is defined by restriction of carbohydrate intake to 20 to 50 gram, and which is just 6 to 10% of the total caloric intake. Low carbohydrate diet is when the carbohydrate intake is less than 26%, moderate when it is between 26 to 45%, and high when the carbohydrate intake is more than 45%. So low calorie diets, especially around 800 to 1000 calories per day, promotes weight loss and improves insulin sensitivity. And in meta-analysis of various weight loss methods, very low calorie diet has showed the most significant weight loss effect. So how we can achieve and how we can promote weight loss, it can be done by reducing the intake of refined carbohydrates and sugars. Mediterranean diet, which is rich in healthy fiber, fats, and antioxidants. it reduces inflammation. Plant-based diets are also useful that emphasize legumes, vegetable, and whole grains. Regular exercise, including aerobic, the Look Ahead trial, that study, participants were advised to do at least 175 minutes per week of regular aerobic activities. So millets can also be beneficial for achieving diabetes remission. So even WHO declared 2023 as the International Year of Millets. Millets like jowar, bajra, ragi, they are gaining prominence in diabetes management due to their high fiber content and low glycemic index properties. And patients should also include probiotic-rich foods to improve the gut microbiome health. So this is a diagram which shows a comparative analysis of the weight loss which can be achieved by various techniques. So average weight change of participants completing at least 1 year intervention, and it is based on a review of 80 studies. So we can see that the maximum weight loss is achieved by very low calorie diet, which we can see. So the weight loss around, it is maximum at 6 months, which tends to again gain. So if we see at 12 months, so weight loss achieved is around 10 to 12 kgs, and which uh, tends to weight loss is, it tends to offshoot. And if we see at around 3 years, still around 6 to 8 kg weight loss is there with very low energy diet. Exercise alone, very less weight loss at 12 months, just 1 to 2 kg weight loss. Diet plus exercise, better result at 12 months, around 6 to 8 kg. Orlistat, we know that result is around 6, maximum 5 to 6 kg. So we have seen that very low energy diet, even meta-analysis has showed that it can achieve the maximum weight loss among the various lifestyle interventions. So the last technique for achieving diabetes remission is pharmacotherapy. So we must be confusing that the definition for diabetes remission, it said that we should achieve HbA1c less than 6.5 without any pharmacotherapy. So the very concept of remission envisages the withdrawal of all types of anti-diabetic treatment, but initial intensive pharmacotherapy can help in achieving diabetes remission. So including near normoglycemia with short-term intensive anti-hyperglycemic therapy may allow some beta cell recovery, which when coupled with more optimal health behaviors may result in remission. So the most uh, benefit in pharmacotherapy and the most important concept is intensive insulin therapy. So it was seen that remission was observed in newly diagnosed diabetes patients if they were given 2 to 3 weeks of intensive insulin therapy. And remission following intensive insulin therapy has been demonstrated to last more than 2 years. So this is the comparison of continuous subcutaneous insulin infusion, multiple dose injection or OHA. So we can see that the maximum percentage of patients achieving diabetes remission was with continuous subcutaneous insulin infusion. So at 360 days, if patients, they received 2 weeks of intensive insulin therapy through CSII, the percentage of remission at 360 days was around 60%. GLP-1 receptor agonist and most recently tirzepatide, a dual agonist of GLP-1 and GIP, have shown a very important effect on weight loss. So recently, these drugs have also They are also available in India, and last 6 months have seen an increase in the usage of these drugs. So they can achieve a weight loss of around 10 to 15%, tirzepatide even more than 15%. So these are potential agents with a great capacity for diabetes remission. So tirzepatide trial, it showed that remission rate of diabetes was 66 to 81%, dependent on the drug dose over 52 weeks. Similarly, some other studies were done. Basically, these studies tried to achieve an intensive, strict glycemic control with a combination of drugs. So in the REMIT trial, the intervention group received a combination of metformin, acarbose, and glargine. Similarly, REMIT DAPA used glargine, metformin, and dapagliflozin. So both these studies demonstrated the potential of intensive combined therapy. So intensive combined therapy means non-insulin anti-diabetic drugs and insulin. So up to 25% of patients in REMIT trial and 14% patients in REMIT DAPA trial achieved remission after 1 year, with the likelihood of success increasing with a longer treatment duration. So if we combine insulin with non-insulin anti-diabetic therapies in the initial stage of diabetes, so this can also help in achieving diabetes remission. So these are the various clinical trials which assessed all the three basic modalities for achieving diabetes remission. So we can see that these are the landmark trials of each technique, that is direct trial, which used a low calorie diet of around 800 to 850 calories per day with structured food reintroduction and long-term support. So the diabetes remission rate was 46% at 12 months and 36% at 24 months. ARMMS type 2 diabetes trial, it compared metabolic surgery versus medical lifestyle intervention for diabetes remission. So patients were randomized to metabolic surgery either through gastric bypass or sleeve gastrectomy or through medical and lifestyle management. So obviously the diabetes remission rate was far higher in the surgical group, that is 37.5% compared to 2.6% in the medical lifestyle group. SURPASS-1 trial, it evaluated the tirzepatide's role in glycemic control. So they were randomized to receive the different dosages of tirzepatide, that is 5, 10 or 15 milligram as compared to placebo for 40 weeks. So 52% of participants on 15 milligram, they achieved normoglycemia without any additional medication. Step 2 trial, it assessed the role of semaglutide. So patients received semaglutide 2.4 milligram for weekly for 68 weeks. So significant weight loss and glycemic control was achieved, but remission rates were not explicitly stated in this trial. And this was the famous Stampede trial, which compared bariatric surgery versus intensive medical therapy for diabetes remission. So patients were randomized to Roux-en-Y gastric bypass, sleeve gastrectomy, or medical therapy. So 29% of surgical group, it achieved HbA1c less than 6 without diabetes medications at 5 years. So this trial was done in 2017. So at that time, the previous definition of diabetes remission was used for defining the diabetes remission. So to summarize, this is a new era, and in this new era, we are beginning to envision and even to detail diabetes remission as the number one management target for diabetes management. So diabetes remission, it is not a myth. It is actually a reality, and with the newer approaches being used and beginning to evolve, so diabetes remission is definitely achievable. But we have to categorize the patients and we have to select the patient judiciously. So best results will be obviously obtained in newly diagnosed type 2 diabetes patients being given early intervention, and it can be reliably sent into remission for at least 1 to 5 years if we are able to achieve a sustained weight loss of more than 10 kg. Thank you.
Thank you, Dr. Rujul. Really a wonderful talk. As we can gather from your talk that obesity is the mother of diabetes. So we have to tackle obesity by any means, be it bariatric surgery, be it lifestyle intervention, or be it medications. So we have to tackle obesity. But the million-dollar question is, what is obesity? How to define obesity? As we know that obesity in our Western counterpart is measured by BMI, but in India, because we are having more adiposity, and we have more visceral adiposity. So for Indian population, instead of BMI, the measure should be waist hip ratio. So what is your opinion on this topic?
Definitely, sir. Because we have seen that even in lean patients in the Asian counterpart, they are disproportionately at a higher risk for diabetes, and even with normal BMI, their metabolic complications are higher. So waist circumference and waist hip ratio, they are better predictors of the metabolic complications as compared to BMI in the Indian patients. Recently, even neck circumference has also been uh, used in various studies, and it is also coming up as a better predictor of the obesity risk.
There is one question from the delegates. Is there any method to quantify beta cell reserve? Do we recommend assessing beta cell reserve before trying for diabetes remission?
So there is one quantifiable measure of assessing beta cell reserve, that is C-peptide. But till now, there is no such defined uh, value of C-peptide by which we can say that above this cutoff or below this cutoff, the diabetes remission chances are high or less. But indirectly, we can see that if patient is requiring secretagogues or insulin, so those subset of patients are less likely to achieve diabetes remission. But yes, studies are going on, and beta cell reserve can be quantified by C-peptide. So it is one of the parameters in future by which we may be able to pick up patients who are more good candidates for achieving diabetes remission.
I think in one expert consensus statement, the C peptide level of less than 7 was considered as a good reserve.
Yes, yes, sir.
There is another question. How to achieve basically obesity control by intermittent fasting or calorie restriction?
So
Or are they interchangeable term, or are they different terms?
they are basically different terms. So meta-analysis has showed that energy restriction or very low calorie diets, basically between 800 to 1000 calories, they are best in achieving weight loss of sustained weight loss of around 10 to 12 kgs, and which can help in diabetes remission.
And a word about intermittent fasting also, because that is again a measure for achieving diabetes remission.
Yes, intermittent fasting can also help in achieving diabetes remission. It is one of the techniques for achieving weight loss, but still the sustained results are much better with very low calorie diet. We can say that low carbohydrate or ketogenic diet, which can give the sustained weight loss.
Dr. Rojul, we have seen that in Indian population, there is increased expression of incretin as well as glucosidase in our guts. So, do we have any measures to counter these typical features of Indian diabetic population?
Yes, sir, definitely, because alpha glucosidase inhibitors, they are not given much importance, much prominence in the Western guidelines for diabetes management. But in the Indian settings, carbohydrate is the predominant fraction. So alpha glucosidase inhibitors are definitely useful in the Indian settings, and increased expression of uh, incretin hormones, which is ultimately abnormal in the diabetes pathophysiology. So, based on this, incretin-based pharmacotherapy like DPP-4 inhibitors and more recently GLP-1 agonists, they are much more efficacious in Indian subset of patients. Some studies have even shown that the efficacy of DPP-4 inhibitors is slightly better in the South Asian population as compared to the Western population.
There is another question from the delegates. Sir, what is the role of pro-insulin and pre-pro-insulin in management of diabetes? A lot of labs are offering these tests in health packages.
So these are basically more useful in the research setting. So some labs are offering them in health packages, but usage of these markers in the day-to-day diabetes management is still not much standardized, because it was seen that pro-insulin is better as compared to insulin. Even for evaluation of hypoglycemia, pro-insulin has been shown to a better marker because of its metabolic stability as compared to insulin. But routine usage in the management of diabetes is still not relevant much.
Uh, there is a fad these days, and many of our patients are adopting ketogenic diet. Can you tell us some good points and some risk factors, some of the risks involved with ketogenic diet?
So, a good point is that ketogenic diet, basically, it is also a term for very low carbohydrate diet. It can help in achieving a crash weight loss, maximum weight loss at 3 months. But bad point is that sustainability is definitely difficult, and it should always be done in a supervised manner with a proper dedicated team, because major health risks can also be there: increased risk of gallstones, some metabolic complications. So if unsupervised, it can be sometimes risky.
Thank you, Dr. Rujul, for a wonderful talk.
Uh, Thank you, Dr. Ju, for your very enlightening talk. And your talk has rekindled hope in, I think, many people that they will, many diabetics who will be able to achieve the uh, remission. And I also thank all the participants, though they are few, but I'm sure they all have benefited a lot by your talk. Thank you, Dr. Rujul, and good night, everyone.
Thank you.
Thank you. Good night. Signing off.